their power comes from wadi, comes from this ability to endure, you know? And so I think they also see it as a threat to their strength as women. But there's also a political economic side to this analysis. Did anybody observe that or connect with that issue? I think that's what's one of the things that's really good about this article. It's not just a cultural explanation.
Because when they use analysis, it will take time, more time to conceive, and so in urban settings they can't afford to do that. They need to move the patients. You know, there are so many patients in the wards, so using analgesics is not an option for them.
Okay.
So the whole process will be easier. It will invoke pain, and also it will be quick as well, the consumption.
Okay, right, exactly, right. It's for, as she says, crowd control. Yeah, exactly. A crowded hospital in Tamil Nadu where there's women, you know, going through labor in the hallway. The Pitocin will speed up the queue. Yeah, exactly. And she also mentions that in a public hospital with very few anesthesiologists, you know, the demand is very great on those doctors, and so they will only be used for things like C-sections, situations where it's absolutely unavoidable. They will not be used for problems that have to do with the comfort of the patient. So she's kind of showing us how, in a way, she's saying these two things emerge together. That in a way, the economic structure of the hospital is taking advantage of the cultural beliefs. You know, it helps to rationalize the very practical things that they're doing, like speeding up the queue and dealing with the fact that they only have, you know, one or two anesthesiologists in the hospital. So I think that's a very important aspect of her research, to kind of simply not get this, you know, and she kind of explains that these cultural and, you know, technological, economic issues emerge together. Yeah. Mm-hmm.
I have two observations.
Yeah.
From the article. So one is they mentioned about the caste notion of pregnancy, caste notion of pregnancy and the purity and pollution.
Yeah.
So during the 1990s in Tamil Nadu, so there were separate pregnancy ward for the lower caste and the upper caste. They don't want to mingle with each other, so they build a different or separate ward for those who belongs to the lower and the upper caste. Then the other thing is, interestingly found that during the Enlightenment era in 18th and 19th century, the doctors and the society started considering the pregnant woman as a regular human being to constructed as a patient. They started treating the pregnant woman as a patient.
Right. Mm-hmm. Right. Those are good points. Yeah, and I think the second point referred to her discussion of the literature, which is quite extensive on reproduction. And one of her important contributions there too is, you know, there are those who have written about how the technologies of childbirth kind of takes, you know, childbirth out of the hands of the mother and into the doctor, into the biomedical system. But then she says, you know, however, the Tamil women happily embrace, you know, hospital delivery. You know, that's not a simple situation of kind of like Ida Susser's article, you know, where, oh yeah, they have these local beliefs, but they also talk in terms of biomedical medical categories as well. She's trying to, you know, sort of push back against the literature that that, you know, somehow it's the women are against, you know, these technologies, but. And yeah, the caste segregation, yeah, is an important observation too.
So, it also, I feel like the penetration of the biomedical models of birth in the global south is not just like a monolithic entity. It's just shaped, and especially in this context, I see like a lot of agency to these women as well. They've transforming these biomedical models of childbirth.
Yeah, that's exactly right. That's exactly her point. That's well said. Yeah, exactly. These women have agency in engaging with these technologies, but to a certain extent, because she kind of shows that there is the fact of the hospital takes advantage of their beliefs, to rationalize. So again, there's always that space between agency and structure. That's the maneuver space, and it's always limited.
And they also mention these cultural narratives, not only making them like Shivan Shakti, that means like without Shivan is a.
Oh yes, yeah.
And all these narratives, it's not like making them very powerful, whereas it's making them to be subordinate. And that she is mentioning about it. And second thing is, in the Western countries, like I think the USA and all, like husband need to stand with the women if he is tailoring shape, right? But
Sometimes, yeah.
In India case, like it's completely isolated. There is
Right.
no responsibility of husband
Right.
and all. Like
Yeah.
they are carrying over the child only. But in India, it's also not possible because I think the education, which is not, it's particularly in the case of Tamil Nadu, I came from Tamil Nadu, still some of the women was criticized for giving birth for a girl child. It's not like men who is related to, still now that situation is there in the rural areas, so it makes more complicated in this cultural things as well.
Okay, right, yeah, exactly, yeah. Well, thank you for adding those layers, to the situation.
I just wanted to ask that Kerala and Tamil Nadu adjacent to each other. Kerala has the highest female-male ratio. So does it also happen similarly in Kerala, this thing about girl child?
Well, I think, what do you who are from Kerala or Professor Ravi, do you have any thoughts about that? He's asked, yeah, go ahead, yeah.
Like Tamil Nadu and Kerala are adjacent to each other. I come from Haryana. Haryana, people, there is this aborting babies through ultrasound, because of which we got this prevention of this prenatal diagnosis and all that. My question is, Madam is saying that in Tamil Nadu, it's still, even today, they blame the women for bearing a girl child. How does it happen? How is it seen here in Kerala, where female-male ratio is so high, the maximum in the country?
Yeah, sex-selective abortion is not a big thing in Kerala. Kerala has a legacy of many groups, Muslims, Hindus, being matrilineal. So girl child is preferred because before the colonial and the post-independence structure of patriarchy and patriarchy like of inheritance coming into place, communities were many communities were matrilineal. So there was actually a preference for a girl child than a boy.
Yeah, because that way you could pass on the family and the property through the girl. Yeah, that's an important story. If some of you don't know it about Kerala, they had like families like Nayars or Eravas that were matrilineal. I mean, still are to some degree maybe, but there's like patriarchy has kind of overlaid, and women would have several husbands too, but then.
And it was acceptable to have, like a serial monogamy.
Yeah.
You could kick one fellow out.
Yeah. But, right.
Not now, but
Earlier there was there is a Swayamvara concept. The lady chooses husband.
Yeah.
The lady is given the thought, like she can choose who the husband is, not the other way around. It is now that.
Right.
So
Okay.
that was in favor of ladies, given more of consideration. I think in Kerala, in culture also it was there. And now still it is in the Kannur side, Muslims, the boy has to give the dowry.
Oh, okay.
So still
Oh.
it is the females are given a higher threshold in Kerala.
Okay. Yeah.
I think gender equality
one
is
day
a So it is always female. There is in Kerala, or this girl is considered to be, I think, a bit of auspicious also. Many prefer girls than boys.
So yeah, no, Kerala has.
After baby babies start coming to this paper, maybe that's why I'm thinking like this. Birthing in Europe and US and working in India, the experience is different. Just like the way cancer is different in New York and Botswana. In India, we have huge, the problem with postpartum hemorrhage. Many women used to die of bleeding, and 500 ml blood loss in the West is nothing, but with an anemic mother here, that would kill. So the uterus needing to contract is a medical requirement. So pitocin and then after delivery methergine is religiously, I've done it 150 times. So,
okay.
we are trained to do that because we shouldn't use the woman for blood loss. And blood loss and it's linked to anemia, so that's another complex issue. And blood availability is another big challenge. So just like the lack of anesthetists, there's a lack of blood banks and safe blood.
Oh, I see. Okay.
That's another aspect which could be why we have this kind here, alongside the cultural and the
Right.
anesthesia. She has mentioned about the professionalization of anesthesia, because historically we had nurses giving anesthesia at the time of independence, but now that's not possible. And the government has at times attempted to train the obstetricians on 3-month course of anesthesia, which the anesthesia professional associations have kind of, that they have not permitted that happen. So this professionalization of anesthesia pain relief also, I think, is, and she's mentioned that in some way, the lack of trained anesthetists. But there is this, I think, pain relief becoming professional, and we don't have enough professionals to do that.
Okay. Right. Okay.
And so, like, I have a doubt, like, she's also mentioning in the Apollo hospital, there are breathing exercises for in the blood. And in the rural areas, like Lochikupam and all, they're giving this kasayam, which is made of dry ginger. So, I have two doubts here. One is, in the hospitals, anyway, they are giving enigma to bring out all the excess things before giving the birth. Similarly, this dry ginger works like that. I don't know how far, that much extent, but usually it's like what she is also mentioning, during the delivery only they use the hospital. Then the post-delivery they use home things. It's very much common in Tamil Nadu. I don't know about Kerala to comment about it, but in Tamil Nadu, we will go to the hospital until unless it's very serious. Otherwise, how much we can able to manage it.
Right.
Drinking of this dry ginger whatever, it's part and parcel of our society. And when we are considering the Apollo breathing exercise, it's a privilege thing. And there is a need to criticize this ginger water also, which is their own capacity, what they can able to remove this extra things before delivery things. How do you look about it?
I mean, I think those are interesting observations. I mean, I like the takeaway that I get from the Kashayam, which I think is a really interesting addition to her claims, is that, to kind of show us that the idea of Pitocin-inducing drugs is not a foreign idea. That they use Kashayams to induce labor. So, in a way, the biomedical procedure falls on fertile ground. That's actually a phrase from Claudia Long's article about the depression in Ayurveda, a lot of the biomedical, biological orientation of biomedicine actually is very compatible with Ayurveda. So the biomedical psychiatric concepts fall on fertile ground, in Ayurveda. I think that these birth technologies of biomedicine also fall on fertile ground, given the local scene, given the local, use of kashayams, and then Nawali and all that stuff. I don't know if that was addressing, but I think that the kashayam point is very interesting one. But now it's used differently, like the kashayams are adjusted, so the kashayams are used to test, right, if the labor is real before you would go to the hospital. So that's a good example of the cultural and the biotech. They're happy to go to the hospital but first they'll use the Kashayam test to see if they're ready, if the labor is real, before they go. Let's move on to Donna Davis. Yeah. Yeah.
So you had mentioned about infertility. In India, it is worse to have no children at all. Second worst is female child baby in some places. Second worst scenario is having a female child. And the best case is having a male child in at least some parts of India. I'm not judging.
Yeah.
So in United States, how is infertility seen? Is it stigmatized?
Having a girl child?
No, infertility.
Oh, infertility. Well, sometimes it's not infertility. Sometimes it's a choice. It's not very stigmatized. You know, I mean, some people may wonder, like, why do you know, sometimes professional couples won't have a child because, you know, maybe they never consciously said this to each other, but they just became too busy, you know. And so, I think some people may say, oh, that's kind of sad, you know, that you prioritize your career so much that you decide you have no time for a family. But it's, you know, the normal thing is to have a child, you know. And generally in the US, the preference is to have children. It's also patriarchal society where I wouldn't say the preference is for a boy child, but the power structure favors men. And
derogatory word for an infertile woman.
I don't know. What is, in Malayalam, what is it? Nalada.
It's like derogatory about a woman who's infertile. And I think several Indian languages have.
Yeah, in Tamil also it's Malali, it's called Malali.
Malali, okay. I mean, people will say barren, which is, you know, like a negative term. But increasingly, it's more like, you know, people don't talk about women as being infertile because, like, increasingly fertility is seen as a choice, especially with IVF. You know, many people are using IVF if they're infertile, and the only issue is the money. Can you afford to do the procedure? Increasingly, India has become a destination. Well, for a while, there's one of my PhD students did a dissertation on IVF tourism. I mean, it's not really just tourism, but, you know, people who visit India for IVF. So having a child is more like not a question of the body's capacity, but the couple's choice. Actually, right now, the son of my friend in Kerala, I have a close friend, Girish, you know, in Trivandrum, his son is in the U.S., and they're going to go get their twins in Mexico. Which they're having through IVF and surrogacy because of infertility issues. So it's a very complex procedure of having to go to this other country to, you know, so I think there's, I mean, many people write about reproduction issues. Not my area of expertise. It's such a broad area in medical anthropology. I'm sure someone has analyzed this in great deal, the whole meaning of IVF and the stigma of barrenness and whether that has changed, and whether it's a class issue now, you know, the ability to not have children or the choice not to have children. Let's move on to Donna Davis. The introduction I've given you from the book Reproductive Injustice. So unfortunately, this is an introduction, so less ethnographic and more discussion of the literature and the meaning of her work. But I'm actually thinking for those of you who are working on reproductive issues and gender issues, you may find her introduction a useful review of the literature. So let me just go to... Here's the publisher's page, so you can see how it actually looks. So Donna Ayn Davis, she goes mostly by Donna. And she's my colleague. She teaches along with me also at the CUNY Graduate Center. And her specialty has been, race and racism, and not just the healthcare system. Her first book is about battered women, women victims of domestic violence who live in a special shelter for women in this situation and who are also poor. And she shows you how they survive, how they negotiate, how hard it is to be poor in the U.S. And so poverty, racism, healthcare, mostly from the perspective of race and racism. I think this article, aside from the actual content, has some good examples about doing ethnography as a form of writing and interpretation. I mean, she spends some time at the beginning, she has her introductory story, which is standard part of the writing genre, and then she goes on to talk about representation issues. She's worried, let's see, where's the term? She's worried about ethnoporn. There's a tendency, to, if you're going to write about the Black experience in the U.S., you use the most dramatic examples, and the sort of more everyday experiences are overlooked and kind of exoticized. And then she explains that she decided that there was no way to anesthetize women's descriptions of pregnancies that ended up in premature birth. And if women were willing to disclose the trauma of their pregnancies, then I could not write around what happened or the feelings that surfaced. So she's trying to be sensitive about what the women are revealing, and sensitive about portrayals of Black experience in American culture. By the way, the thing that she's referring to, this ethnoporn, there's actually a very, very good film if you want to understand race relations in America, a very entertaining and clever film. This one, highly recommended. It's about a Black author who writes books about, where the characters are Black, but they're like middle class and they're healthy and things are fine, and there's problems in their lives of relationships, but all of the people who get all of the media attention are the people who write memoirs about growing up in terrible neighborhoods, becoming gang members, it's one of these things that the cultural critique is excellent. It's also very funny, the way they use, humor can sometimes be the best critical perspective. She's trying to avoid falling into what the main character in that film is also trying to avoid and has trouble doing. I'll just tell you, the premise of the film is he's trying to satirize, he makes up a ridiculous story that exaggerates all the stereotypes to just kind of as a joke, but publishers become interested in this and they want to publish it, and it's a joke that becomes real in the movie. And so, in addition to this issue, we see also. I don't know. I'm probably more likely one of the ones you have to pay for. I'm guessing. Maybe here it's on YouTube, but Netflix or Prime or something, I would think. Of course, the market is different in India. And let me just look at another thing here about her interview. So she's talking about the interview with Ashley, about her experience. her introductory vignette. She tells us that one weekend, let me actually make this bigger. One weekend, when her parents were out of town, things took a turn for the worse. Ashley shared with me, "It was early in the morning, I was confused." You notice also how she's narrativizing the interview. It's not just like scientific, like some psychologists use. So-and-so said this, a little excerpt. This other person said this, just a little excerpt. Ashley shared with me, "It was early morning, I was confused, scared, and bleeding. I went to the hospital and they put me on magnesium for hypertension so I wouldn't have seizures. I was at a teaching hospital. The nurses wanted to put in the IV, but I was swollen. My hands looked like I was a drug addict. The people at the hospital were talking to me, but I did not hear what they were saying. I finally only understood what was happening later because my grandmother and my aunt, who were both medical professionals, came later and explained what was going on to me. It was at this point that Ashley's placenta previa had been diagnosed. In a brief departure from the story of her unexpected labor, Ashley then began to tell me about her aunt, who had been a midwife for 10 or 15 years. I think this was Ashley's version of taking a small break, because when she resumed talking about the birth, she began speaking rapidly. So that's a good example of the interpretations you do as the ethnographer. You're not just repeating the speech, but you're saying, oh, in the middle of this, she began to tell this long story about her aunt, which she interprets as Ashley taking a break from the more emotionally heavy explanation, which she returns to. When I arrived at the hospital, they tried to keep me on bed rest most of the day, blah, 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 and then she becomes more agitated, more rapid. So those are things too, what is the demeanor of the interviewee? Are they beginning to speak fast, with urgency because something, and so we're allowed to make these interpretations, in our writing up of the interview, not just presenting excerpts that maybe fit in a table or categories that we've determined in our research study, but to kind of be more of a dialogue between ethnographer and interviewee. and then she, oops. Wait, where did I go here? And then she says, I was in the hospital for about 3 days. Jamie was in the hospital from January 10th to March 6th, so her baby was born, like 1 kilo, very low birth weight. And then Donna Davis writes, "It is January 9th. I thought to myself. At that moment, I realized we were having our conversation just 1 day before the anniversary of Jamie's arrival. Worried, I wonder if it was too difficult to continue the conversation. Should I offer to end it? I asked, but Ashley said she wanted to continue, although just after sharing with me the details of her admission to the emergency room, there was silence on the phone, and I broke it with..." So that's also, I think, good examples of these issues of how you do ethnography in terms of how you write it up. And that she's showing her awareness of we were talking earlier about the ethical issues of interviewing. She's showing her awareness of the vulnerability of her interviewees, and how she interpreted that, how she assessed whether she should go on with this conversation given the timing. So I just wanted to offer those, along with earlier Julie Livingston quoting her own field notes as examples of ethnographic writing. How you present. Well, I think this one being something I'm more favorable to than quoting your own field notes. But let me ask you what you got from this introduction to her book, Reproductive Injustice. What insights is she trying to share?
Let's speak to this incident.
Yeah.
Where the cannula was supposedly removed by the nurse, and part of the skin came marks
Oh, yeah.
in this particular incident. Is it a perception that the nurse otherwise would have been careless, whether
Yeah.
she was white or
Hmm.
African American? She would have either ways been, or was it the perception of Ashley that because she was African American, so she was very brusque and very.
Oh, well, we don't know. You know, and I think that Donna Davis's choice is to, you know, take seriously the claim of the interviewee. You know, I can't actually imagine myself how the skin would come off from removing some surgical tape, but maybe this can happen, you know. But she doesn't really question that. She just reports that Ashley said that this happened. But the important issue is the nurse, you know, kind of reacting, you know, gruffly to her when this is an issue of her own small child is the important, you know. It's hard to we can sometimes really only go by the claim, because that's all we have. No way to kind of see godlike into what really happened.
And in somewhere it's also mentioned that it's not about ethnicity. They are behaving to everyone, but it's based on their economic things. And in the case of Ashley, she's younger also. That
Right.
her age also it's matter. That's
Okay.
also mentioned. Like she's 19 or 20, so like they won't give that much importance. This family thing, cultural
Right.
preference,
Mhm. That's right. Well, it is also about ethnicity, you know, but the economic status also can be another factor. I mean, one of her more important points that she tries to bring across, that it's not just white healthcare workers having certain attitudes and interactions with black patients. The black healthcare workers also treat the black patients the same way. In other words, she says it's not the ethnicity of the caregiver or the medical professional, it's the ethnicity of the patient that seems to determine. I mean, in the US, you also have similarly, like in cases of police brutality, you'll have black policemen beating up black suspects as well as white policemen doing this too. So it's the sort of the identity of the victim, as it were, that's the key factor. Are there other observations of what you got from this?
The use of medical terms, I think, would set up in the middle. I mean, even it necessarily may not be the race there. If I talk to somebody comes with an issue and I use medical jargon, this seems
Yeah.
to be a lateral infarct, but your analysis file, I initiate the stroke protocol nonetheless. The other person would be, and by using medical jargon and kind of establishing my superiority of the knowledge of what's happening. So how to tease that out from the race-related experience?
Oh, you mean how the use of medical terms might be interpreted by?
The medical establishment itself would be, it's another way of, I mean, it's unequal. The doctor-patient
Yeah. Oh, yeah.
is unequal.
Yes.
So that is there in play. Now, in addition to that, we have to preserve the racial aspect.
Right. Yeah. There's.
If you read the whole book, it will be more evident, but how she got there, I think it's easy.
So yeah, you're observing that there are multiple hierarchies involved. Yeah, and the doctor-patient and some encounters that are merely doctor-patient style may be interpreted by a black patient as being, they may see things having to do with race that the white patient may not see. It's again hard to know what is the reality. It's just that cumulatively, if you look at the larger scale, and as she does in this book with more and more cases, that you find a regularity, in the black patient's reporting more certain behaviors than the white patients do. And you also have different incidents of mortality and perinatal problems too among black patients compared to white. Actually, let me just look at those statistics from page 6. Of course, again, the pagination on this, because I downloaded it from the ebook, is a little bit odd. Page 6 of the PDF, which is different from the pagination in the book. Maybe I've written on the wrong page in my notes. But at several points she gives us these numbers from other people's research. This one is Native American women's reproductive care, where she found the infant mortality rate was 28% higher among Native women. I mean, among the data she explains, and this is a good example of how, you know, anthropologists need epidemiologists and others because everything have to be in a context. So she tells us that somewhere, I've written on the wrong page number, that the maternal mortality rate among black women is 4 times higher than among white women in the US. And then I forget the higher rate of premature births, but that's also several times higher. And that, sorry?
2 times more likely to give prematurely planned.
2 times, right. Yeah, it's just very significant. It's not like 10% more likely, yeah. And even when they adjusted for class, when they included people of the same socioeconomic status, they still found a very significant difference between, you know, black and white women's experiences during childcare and mortality. So this seems to be not just about class, it seems that the racial factor is a factor. One thing that she points out later on in the book, one of the biggest racial ideas that has a negative effect is the belief that black bodies are somehow more resilient, better able to tolerate pain. And because of that, medical staff are more likely to delay interventions into black women, you know, in the birthing situation. There's also a tendency to doubt. Like you remember Ashley saying she wants another ultrasound, and the doctor's saying no. And then, if it was an educated middle-class white woman, they might have more difficulty saying no because they would feel bad about turning down. But if it's a woman remember, she's on some special health insurance program for the poor, that's also an added factor. So if you're perceived as being poor and black, and she's 19, you're perceived as being irresponsible and not very informed, and that informs how the kind of care that is given. She also tells us on page 8 that this work is inspired by critical medical anthropology, a term I gave you before about anthropology that's engaging in, well, political, economic issues, you know, and race and racism would be part of that.
So in that definition, they say that merged theory and praxis, this functional health versus experiential health,
Yeah.
in comparison to contemporary political economies. That definition of critical medical anthropology in this paper.
Or I would say it's looking at the factor of race in relationship to premature birth. That's the political economy. That's the critical medical anthropology aspect. Like we saw in the article about Union Carbide, it was more class that was a factor. In this one, it's more race that's a factor. But they're both considered sort of the purview of critical medical anthropology. You know, that it's about power relations. It's not just about culture. Of course, culture creates these power relations too. There's always a cultural level somewhere. And she also discusses what she calls the afterlife of slavery. Oh, biopolitics, yeah, the term from. She's sometimes a person who's a little bit skeptical of the Foucauldian terms like that, but sometimes, they're kind of the obvious term to use nowadays. But what do you understand as the afterlife of slavery? Do you understand what she means there and what she's bringing up?
She's connecting with the past and present, like even abolition slavery, this system is that I understand that still this system is persist. And I also read another article which is written by Metzel about this schizophrenia or black disease. Where she is also mentioning this, many of these doctors, they are finding this black women or black people, like African people, they are diagnosed with this schizophrenia as compared to the white things.
Right.
Even this mental health diseases also, there is in the hierarchical order, even assigning of the disease also there is a hierarchical order when it's come to the whites and African Americans.
Okay, you're thinking of the Jonathan Metzel book?
Yes.
Yeah, the protest psychosis. Yeah, about race and I'll put that up here. That's a good book to know about. Let's see. I'm not seeing where the publisher's site is. Well, I'll just click on this one so you have the reference from, I think this is a book review of it from Disability Studies Quarterly. So you have the name of the book. How Schizophrenia Became a Black Disease. Well, the afterlife of slavery, I mean, it's not that slavery continues, but the aftermath. And she mentions the fact that, some people, I mean, mostly white people will see black people talking about how they're limited by the social structure, or even bringing up the aftermath of slavery as just, being too stuck in the past, being hung up on issues that have been resolved. I mean, and again, there are very different views within the U.S. of these things. I mean, there are many Americans, more likely white than black, that will say, we've solved the problems of racism. Hey, Barack Obama was our president, the highest position of power. That's true, that's very good. But while Barack Obama was president, and even afterwards, the typical black family still had much less money than the typical white family. And then with other categories like Latino, Asian American, also in those hierarchies.
You see similar patterns in the caste system in India.
Okay.
How Draupadi Murmu is the president who came from like a background which is not usually like marginalized.
Right, yeah. So Ambedkar wrote the Constitution, and he's from, so there must be no caste prejudice in India because of that. So yeah, it's a similar situation. And people have written about the degree to which, race in the US is like caste in India. In both places, you can have exceptions, right, to the rule. I mean, caste, there's an economic hierarchy that it goes with, but you can have wealthy Dalit people and powerful ones, and you can have poor Brahmins, but most of the time, it's not that way, right? Most of the time, it tends to go, no, sorry, let me just silence, my phone is buzzing. Put it on mute. Anyway, yeah, I mean, there's, so like you can have rich and powerful black Americans and poor white people. But those are the exceptions to the general trends in both places. And forms of discrimination obviously still continued against caste and against race in both contexts. And the afterlife of slavery actually is, in a way, I'm more and more convinced that, although slavery ended in 1865, that the current racial segregation is still the aftermath of that. That if you consider, it wasn't just, so slavery stopped, but then it's not like suddenly wealth flowed into the black population. In fact, what happened is there was a period called Reconstruction after the US Civil War, which was over slavery, among other things. Suddenly, black people were free, and they did things like they ran for political office, and they got elected right away after slavery. It's like, oh, this is amazing. Well, suddenly we changed the laws and looks. But many white people said, oh no, this is terrible. They're freed, but now they're taking positions of power. So they implemented all of these draconian limitations, and even had violent vigilante mobs that, if a black person was running for office, then suddenly this white, Ku Klux Klan is a famous one of these vigilante groups. They would burn a cross in front of the home of the black person who wanted to run for office. And the person would understand the threat, that if they continued, then they would be killed themselves. They would be hung. Lynchings happened, where a white mob would take a black person and hang them from a tree. And then there were legalized segregation occurred too. They realized, oh, we've freed black people, but now they're mixing with white people, so we can't have that. So many things were segregated: access to power, access to property. And it wasn't until 1960s that the civil rights movement in the US that got rid of all of the segregation laws. So it's really only since 1960s that we have, and because wealth, is inherited by families, there still is, in a way, the aftermath of slavery. It's not just the slavery, it's all of the segregation and very literal legal and political and violent attempts to keep black people marginalized since then that has resulted in continued, very strong economic and political differences with some very important exceptions as well at the same time. Anyway, I realize we are out of time. So for tomorrow, again, we'll talk about this. So in terms of actual ethnographic methods, addressed from a very sort of more careful and programmatic perspective, this book by Bernard is an important one. It basically tells you about research methods. The chapter I chose is about interviews, the kinds of interviews you use in ethnography, because elsewhere we're talking about participant observations from other angles. And then this, Seth Holmes, I've given you the introduction. Seth Holmes's book is Participant Observation Done in an Extreme Way. You may have mentioned that I said in this book, the anthropologist goes from Mexico with migrant workers and illegally crosses the border with them to see what that experience is like, and gets arrested by the Border Patrol along with the migrant workers. So I think it's a really interesting example of participant observation in a kind of a really bold, and great storytelling. It's like very page-turner readable to hear his story about how that works. And then maybe we'll talk about those two for the first hour, and then we can have, hopefully a little more time for you to all share your observations that you came up with from this exercise.